prepare for a seamless transition from paper charts to the electronic health record. My name is Paula Peter, and I'll be your host today as we journey through a successful go-live day and what it's going to take to get there. Before I begin, I'd like to tell you a little bit about myself and why I chose today's topic. So again, my name is Paula Peter. I work for Galen Healthcare, where I'm a Galen certified EHR consultant. I have 18 years of healthcare IT experience and 5 years of V11 hands-on experience with Galen. I've worked in all types of roles, starting with upgrades, project management, and worked on the upgrade team for a while, and then I moved into Galen's service team, which just means I travel from client to client site now and assist them with setting up StimSet, doing some net new implementations. I do workflow assessments and optimizations, and I still do build and design work, and recently a lot of training, both functionality and system administration training. The next thing I hope to do is to get Galen certified in advanced note building and start focusing on ICD-10 and meaningful use phase 2, 3, 4, 5, 6, etc. So for the reason I decided on today's topic, it's really simple. Within the last 6 months or so, I had an opportunity to visit some clients on Go Live Day after they were transitioned from paper to the electronic health record, and what I ran into was quite shocking. The worst was the patient data missing from the actual charts, to be more specific, the provider's notes, to equipment not working or not where it should be. The waiting rooms were crowded, and of course the providers were getting more frustrated. So after a couple of these go-live support jobs, I decided I need to get that word out. I just need to make sure that if anybody is going to be going from paper to electronic health record or is in the process right now, to just remind them of the things that you're going to be wanting to look for, and make some decisions long before, if you can, before you actually set a go-live date to transition. Because time is everything with these things. There's a lot that has to happen, and I'd like to help anyone I can avoid some of the more common mistakes. So before I do get started, I need to tell you that your phones have been muted, and if you have any questions, please go ahead and type them in the question panel, and at the end of the webcast, I'll do my best to answer as many questions as I can. Making the tough but right decisions. I won't preach a lot at you, but I do want to say that in order for you to make the right decisions, you're going to have to know what the decisions are. So throughout the presentation, I'm going to highlight some important decisions for you to start thinking about. At the end, after I walk you through the Go Live Day workflows, I'll review what we learned, and hopefully you'll walk away with a better understanding of what you need to do to prepare. So today we'll be talking primarily about these few topics: performing your due diligence prior to go live, ensuring that your practice and patient charts are ready for your providers on go live day. I'm going to go ahead and explain and demonstrate why the abstract process is so important to your go live day, and I have a list of prerequisites at the end to show you before going live, and I'll talk a little bit about best practices, to optimizing the adoption process, physician champions, such things as that. All right, so let's start with performing your due diligence. You can see here I have V11 notes, workflows, meaningful use objectives, additional resources, and go live date. Let's start with the V11 notes. You'll want to make sure to hire a V11 note expert as early in the project as possible. These notes they're not, well, I shouldn't say they're not difficult to build. It's a long process, and building the notes does take a lot of time and resources. You're going to hire a note expert, and they're going to have to sit down with your physicians, and together they're going to come up with the best note for their specialties. So again, just knowing V11 note and how intense and involved they are, you're going to want to start hiring, looking for your note experts and looking for the physicians who are best suited to help you build those notes. Workflows, of course, these are assigned to each of your different roles within the clinic, and you create these workflows by understanding exactly what the users are doing now and what they're going to do to meet meaningful use and stay certified within the EHR. So again, you have to start thinking about hiring a workflow assessment and optimization consultant to walk through each clinic with you, and you want to identify the gaps that you'll need to focus on during training. Once the workflows are approved, they can be documented and used for training, and that'll save you a little extra time there. Also, take advantage of the new workflows. Introducing new workflows is going to give you the perfect opportunity to change the way your clinic operates. So if you have some little things that take up a lot of time or some bad habits that you can break, now would be the time to go ahead and try to work those out during the new workflows. Meaningful use objectives. So we all know that one of the first things you have to do to meet meaningful use is pick the measurable objectives, right? So you can either get those from your StimSet consultant, or you can go out to that CMS website and grab them if you haven't already. But deciding on these measures can be a daunting process. You're going to need to meet with your providers and get a good understanding of what each measure actually means and which specialties in your organization can meet them. Along with all of that meaningful use of measure picking, you're going to have the installation of the actual StimSet. So the StimSet components are delivered by Allscripts, and they're configured by your implementation consultant. So again, anything to do with configuration is going to take a bit of time, so start as early as possible with gathering your MU objectives and hiring your StimSet consultants. Additional resources. Most clients usually require a few more trainers during the transition period. Two basic reasons for this. One, we definitely recommend that you allow time to have hands-on training for your users or computer-based training, specifically for your physician champions or super users. Well, what I mean by this is that once you get your test system up and running, you can engage your physician champions and super users to come in and test drive those workflows for you. And once they've test driven them, you can keep them engaged by giving them a login and a dummy provider and a dummy patient into a test system and let them do their workflows over and over again and give you some feedback. So the benefits are fairly obvious. The more they like it, or rather the more they use it and become familiar with it, the more they're going to like it. It becomes less intimidating. The more they like it, the more they'll talk about it to their peers and hopefully start promoting it. The second reason we hire trainers, or a bunch of them during the end, is go-live training itself. So go-live training is usually 1 or 2 weeks before go-live day, and this training is intended to help the users retain their knowledge versus losing it if they don't use it immediately. So we recommend that classes right before go-live, let's say you have 2 weeks, keep your classes really small so that everyone gets the most out of them, and have a bunch of them going on at the same time. In other words, if you had 6 trainers and they each train 5 people at a time all day long in different training rooms, you're going to be able to knock it out and afford these users to retain that knowledge. So what I'm trying to stress here is training is big. You're going to have to consider resources for that. And of course the go-live date, that's the tricky part. So most clients go live because of either meaningful use or there's some kind of grant that suddenly surfaced and can only be taken advantage of during a certain period. So that's going to be a hard one. So the first thing I would say to do, because I definitely don't want to give you date ranges until I know the size of your clinic and what type of things you have to do for your grant, etc. But the earlier you can go, the better. So if you had time, if you had a good 7 to 10 months lead time before you had to meet meaningful use or meet that grant income date, use it. Start as soon as you can. If you can't wait, you really need to sit down and weigh the cost of rushing that transition. You're going to need to hire a lot of people very quickly and weigh that cost against putting out the EHR prematurely. So weigh those against the actual meaningful use demands and grant income dollars. And again, we can sit down with you and discuss that stuff individually if you decide to make that transition. All right. Ensure your practice and patient charts are adequately prepared for your providers. So take a look at your practice, and as far as preparing your practice, you'll want to do a couple of go-live rehearsals. Make sure all of your scanners are working, your printers are working, your fax machines are working, and that everything's in the right spot. You want to make sure your scanners are in place at the front desk if they're the ones doing the scanning for the insurance cards and licenses, et cetera. You'll want to consider where you're putting your printers to print your, your prescriptions in a secure environment, and don't forget about the paper you have to get. Clinical summaries need to be printed out to make meaningful use. So once you decide who's going to print these or who's going to be responsible for printing these, make sure you get those printers in place and have that printing defaulted. You're going to need to test your practice management system early to make sure that it's sending the data to the EHR, primarily scheduling and the patient demographic data that is required for meaningful use. I could go on and on, obviously, you could probably tell by now, but I promise I'm going to get into the system here in a minute. I just want you to see what you're up against. And if you know anyone, I know a lot of people talk to other clients, if they're going to take on going from paper to EHR, please have them reach out to us and we can give them a hand on that. And lastly, results won't be in the EHR as discrete data because you haven't had a system, right? So you don't have your order results interface up. So that's huge. You're going to want to make sure that the patient's past results have been scanned into the chart viewer and they're easily accessible. Abstraction. So we all pretty much know what the abstraction process is, right? We're going to take out the information we need to be able to perform our job. And this here for the doctor, I'll let you read it for a second, but basically what I want to say here is on go-live day, the provider needs and expects to be able to open up the chart and quickly and easily locate that data. Primarily the discrete data that we need for reporting, which is your current meds, allergies, immunizations, social history, surgical history, active problems, etc. If a clinician enters this data from the paper chart into the EHR, it will go in as verified, and it'll end up in the note for the provider. So when the note goes in, when the provider goes into the note, they're going to be able to view all of this data because it was put in and it was verified. If you choose a non-clinical person to enter the data, or like a data entry firm, it's going to come into the chart as unverified. The provider will not see it in their note, and they're going to have to search for it. It's going to be under different sections of your clinical desktop. It's going to be your problems are going to be under your problems. Your meds will be under your meds, vital signs, etc. But they're going to be in there as unverified, which means not only does the doctor not see what they need on go live morning, they have to go and find it and then verify it before it ends up in their note. So again, abstract process is huge. You need to start that as soon as you know you're going to be transitioning. It takes a lot of work. You're going to have to hire, you want clinicians to do it if you can. And another reason for the clinicians, besides being the better of the two choices, there are laws in place to dictate who can enter data into a patient's chart, even if it's historical data. So the EHR, Allscripts was good enough to put in some preferences, and these preferences are set up per role. And basically what it's telling us is if I'm a non-clinician, I'm going to have these preferences set to verify. So it's going to enable my RX orders verification or problem verification. What that means is someone's going to have to verify that work, and that's going to be the provider. If I'm a clinician, I don't enable these, therefore my data goes straight in and I don't have to worry about it, and the provider will see it. So keep that in mind, abstract process. Also keep in mind that there are professional services available if you find your staff is unavailable to perform this. It's a lot of work. All right, again, just a little bit more on the abstract process and why the clinical staff makes the most sense. Real basic, but very important. They can read the provider's handwriting. They know the medical terminology, signs and symbols, and they know their provider's practice habits. Other decisions, pardon me, revolve around the clinicians. How far back are they going to go to enter the data, and where do they start? So we're going to recommend that you start with patients who are scheduled for the first 2 weeks of go live, if you can, and the patients who you see regularly. How else do we get data into the EHR? So we've abstracted the discrete data that we need, and now we're going to scan the rest. And some folks will scan the whole chart in, and also on top of that have the discrete data entered so that if somebody does forget something or misses something while they're abstracting, it's there in the scan. It's there as a scan document in your chart viewer. So, but one thing to remember, so when you're scanning, scanned data is not discrete data and cannot be reported on or manipulated in any way, right? It's just a scanned document. Depending on the size and volume of your practice, you'll need to weigh the cost of hiring an outside firm or asking internal resources to do the scanning for you. Try to hire a medical scanning firm versus a data entry firm to do your scanning to eliminate unnecessary mistakes. Validating your scan data is huge, so make sure you schedule plenty of time for clinicians or these data validation experts to validate all of the patient data that was scanned in to make sure it's accurate and in the right folder within your chart. Lastly, start scanning as soon as you have access to the EHR and the scan module. Again, that's huge. Depending on your practice, you could have thousands and thousands of charts that have to get scanned in. Do it early. Don't wait until everything's confirmed or tied up. All right. The Go Live preparation checklist. Basically, exactly what it says here, the adoption and preparation meetings. You want to make sure that you have meetings, either weekly or monthly, about the project and what's involved and who's going to do what. You don't want it to be a secret. That's when everybody claims they didn't know what was happening and it all falls apart. So try to have your meetings and make sure your staff and your IT people attend. Your patient data has been entered and scanned into the chart. Your notes and note forms have been created for your specialties. Provider schedules have been reduced. That's huge. The first week of Go Live, I don't want to tell you what to do, but I will give you a recommendation. I would cut it more than in half, to be honest with you. Get those schedules back because they need that learning curve. They need to get at least twice the amount of time to do a patient visit than they do now. So make sure you look at that closely when you're planning on Go Live. Equipment in place, just a review on make sure your scanners are in place, printers are in place. Make sure all of your users have been validated and that you've logged into the system from each location and that your wireless access points are up and running. And of course, make sure your staff and physicians have been thoroughly trained. All right, we're getting there. Adoption and commitment. Who will be your physician champions? Who's going to lead these people? This is big. Again, some of these things we don't think of until afterwards, and we think, geez, if we just had that person to promote this and to make it more important than what it seems, we might have been more successful. So it's critical to the success of your project to engage and maintain the interest of these folks. Get your physician champions out there. Choose, 2 or 3 of them if you have to, and make sure these people know exactly what their role is. One of the best definitions I've found for the physician champion is this, so I'm just going to read it to you. Your physician champion is an expert that provides education, champions a cause or product, or gives support to staff around the diffusion and implementation of clinical practice guidelines and protocols. In all cases, the physician champion is perceived as credible in having the ability to persuade others. Oftentimes, the physician champion is able to influence other physicians to adopt or implement a new or revised process or guideline for the improvement of care quality, or to become a physician champion themselves within their own specialties. That's exactly what it is. So when you're choosing your physician champions or posting it, this would be a good way to, or a good thing to go by. All right, backwards thinking. This is where we're going to start getting into the system. What I think is, in order for you to truly understand and prepare for go-live day after a transition, I think it's important to start at the very end, to see what the end product is, and how well your go-live day could and should go. And once I'm done with the demonstration, we'll review what we've learned through it, and then I can start taking some questions. All right, so day 1. The patient walks in, and the very first thing that's going to happen is that they're going to be greeted by the front desk staff. And that front desk staff, pardon this slide, I had to take a snapshot of this practice management system. The front desk is going to go ahead and check them in, arrive them so that they show up in the EHR has arrived, and review their demographic information. The next thing these folks do is they go into the scan application and they scan in the patient's insurance card and driver's license. The scanning, the driver's license and insurance card should only have to happen this, first time, or of course in a future visit if, the insurance or license information has changed, but it's not in the system, so we need to get it in there. So on go live morning, that's an extra step. They're going to have to grab that insurance card and license and scan it into the scan module. After that, they go ahead and jump into the EHR. All of these icons are sitting on their desk, so they're just going to move from one to the other, but it is quite a bit to keep up with. They're going to jump into the EHR, where I'm going now. And they can see that the patient arrived here, and what they want to do, one of the most important things a front desk person can do for the provider is to make sure their pharmacy is loaded in. The provider will need to be able to electronically prescribe, and without that pharmacy, they're going to be stopped in the middle of their workflow to have that entered. So your front desk person, after they scan in your credit card, your insurance card and license, they're going to go ahead and put in the pharmacy. They do that by hitting this blue eye at your patient profile or information. And we're just going to scroll down here to the bottom and put in a retail pharmacy as well as a mail order pharmacy. That's done here, but I simply can put another one in if I want. I don't want to get in too much with what the system does, especially if you haven't been on the system yet. I just want to show you the overall workflow of the clinic itself. So I'm going to put in the pharmacy, and I'm going to get out of there. The last thing I want to do as a front desk person is I want to make sure that there are no meaningful use alerts for demographics. So I'm just going to go over to the patient's encounter summary and look at my meaningful use alerts. It says here, your language, race, and ethnicity is not documented. That means that it didn't come over from the PM system, so that shouldn't be there. And allergies is not for the front desk person, that's for the nurse or the provider. But the front desk person would want to go here and make sure that the language, race, or ethnicity is documented, and they could do that by going back into that eye and putting that information in. Again, that information comes over from the PM system, and this system's just not set up to receive it, but it should be there. All right, so the other thing the front desk person wants to do is flag the patient's status and location. So my patient just came in and they're sitting in the waiting room and they're ready for the nurse. I've gotten everything I need from them. They're going to go ahead and put nurse ready. This replaces the flags or the lights or whistles or whatever you have indicating where your patients are. This you can do right in the system, and it's important that if you do decide to do it, that everyone in the clinic does it. Otherwise, if the first person who misses it, you've already lost where the patient is. All right. So front desk is done. They're going to go back to the schedule and get ready for the next person. The next person up is the nurse. The nurse is going to come in, and they're going to see the patient has arrived, and they're going to take them back to an exam room, and they're going to go ahead and start taking their vital signs. We recommend that they open a note for the provider and do all of their work in there. So I'm going to show you that workflow. They're going to open the note. For the provider. And note types. Remember when I was talking to you about making sure you have notes built for each specialty? Note types and visit types are the same thing in D11. So we built an established patient. We have a follow-up visit, chronic disease management procedures, et cetera. But right here is where you're going to see all your notes. So if your doctor logs in and doesn't see them, that's a red flag. So going back to note building, make sure your notes are built and make sure your providers, when they're doing your workflow testing, that they can pick all of the notes that they want and that none are missing. All right, so I go into my patient's note type, visit type. Now, workflows vary, so bear with me. You know, some clinics have people put in the chief complaint, others don't, but I'm going to go through the basic, and I'm going to say that the nurse, the very first thing the nurse does is he or she takes the vitals. So they click on the heart, takes them to a vitals panel, which is built by your implementation consultant, and they start putting in their vital signs. Put in whatever, I mean, you can put in as much or as little as you want. I mean, that's dependent on your organization and meaningful use. And I'm going to go ahead and hit OK. The next thing I'm going to do is get their chief complaint. Why are they here? What are they here for today? I'm just going to go into the chief complaint, hit new, or I could free text, and I'm going to say they have abdominal pain, and I'm going to hit OK. All right, so now I'm going to go through their history. I want to double check on any active problems they have. I want to look at perhaps their current meds and just make sure they're still on or what the status is of their meds. I'm going to ask them about their allergies, and I'm going to want to record if they smoke or not for meaningful use, and I would do that under social history. So I can review everything here and from this, so your left-hand content page, or I can come over here and add something new to this. So if I wanted to add a new problem or a smoking status, I would simply hit new and go to the ACI and add something new. But what I'm trying to show you is basically you take the vital signs, you go into your chief complaint, you review the history of the patient, make sure they're not allergic to anything or their allergies are up to date, and record their smoking status. At this point, I can go ahead, and I should have done this before, pardon me, I should have changed this from waiting room to, I put them in the exam room and they're with me now, so I'm just going to put with RN. I apologize. So I've put in the information for the doctor. I'm done. I'm going to go ahead and commit that data. Save and continue. So I'm going to close that for my provider. And hit yes. And I'm going to go back to, before I go back to my daily schedule, pardon me, I do want to double check and look at the counter summary to make sure there's no meaningful use alerts for me. So it says here your allergy list is not reconciled. So that's dependent on your organization, whether or not the nurse reconciles that for you or the provider. More likely the nurse would. So I'm going to go ahead and go to my allergies list and reconcile that so that when my provider comes in, they can see that that's reconciled. And it's gone. Perfect. I'm going to go ahead and continue and change the location. They're still going to sit in exam room 1, but I'm going to say they are provider ready. And I'm going to get out of the chart. I'm going to go back to my daily schedule and wait for my next patient. All right, the doctor's up. The doctor, what we've trained him in training classes is to go ahead and go to the schedule and then just double click on the note that your nurse opened for you. So they're going to go ahead and double click on that. And it'll take them to the note that the nurse opened. And normally what we tell the providers to do is, instead of choosing each one of these sections one at a time, I tell them, go to your view, and you'll be able to look at all of the information on one page. So I'm looking at it, and I can see their chief complaint, their active problems, medical history, social history, current meds, orders, etc., immunizations, allergies, vital signs. Everything I want is right there. Okay? I'm going to stop here for a second, and I'm going to show you what happens when the provider logs in and a non-clinician entered or abstracted the data, rather. So we just saw everything was viewable, in the note. I'm going to go to a patient that came in the day before, and I'm going to open their note, just like I was taught in training, and I'm going to expect to see the same thing. I want to see everything at one shot, and I'm just going to hit view. All I see is a chief complaint, and I'm wondering, where's all the data? We were told that this happened months ago, that all of the data for these patients was going to be in the chart, was going to be in the note. It's not there. So right then and there, you've started chaos in your environment, and something we can absolutely avoid. If that doctor doesn't see data, it's really going to set off a red flag. It's going to start, like I said, frustration. Everyone's going to be aggravated. They're going to have to start trying to find that patient chart, grab your supervisor and try to figure out what's going on. Well, more likely than not, if they said they input the data, they probably did. However, it probably came in as unverified. And to find the data, I would start looking for the data under, if it's a problem I'm looking for, I'm going to go to problems. Voila. There it is. So the data's there. It just came in as unverified, which means I, as the provider, am not going to see it until I verify it. And so you can imagine what's going to happen if I have to come and verify all of this data before I can get into their note. Not only do I have to do their problems, I would have to do the same thing in their meds and orders, allergies. Okay, so when I keep talking about abstract process and making sure the right people do it, that's very real and very serious. You want to make sure that that chart is ready for the provider on go live day. So if nothing else, just make sure that you have someone enter the data as verified. All right, I just had to show you that because that was one of the things that I saw wrong in a few of these clinics. So I'm going to go back to my good patient, and I'm just about done here with the physician workflow. And I hope you can see how quickly and how smoothly that ran, and it's because everything was in place. My practice management system was up and running, so I was easily able to check in my patient and arrive them look at their demographic information, and then I was able to go into scan because my scanner's sitting on my desk, and I scanned in their license and insurance card without having to get up or fight for, a place in line at the scanner copy machine. And then I had access to the EHR, and I knew exactly what I wanted to do once I got there. And then the nurse came in, opened the note for the provider, changed the status and location, took the vital signs, did the chief complaint, and did the history review. Closed the note, and the provider came in, and again, they're all set. They hit view, they look at what they need to, they close, they finish their note, and they can go from there. They can order or do whatever they need to do. So that, to me, was a very smooth transition, and that's pretty much what I wanted to show you here in the system. Not a very long presentation, I'm afraid, but I just really wanted to get the point out that if you are looking to transition from paper to the EHR, please reach out to us and let us know, and we'll go ahead and sit with you and help you figure out the best approach for that. I'm going to go back to my slides, and I'm going to, I didn't want to do that. I want to look at what we've learned. So I just reviewed that with you. Okay, this is where I need practice, obviously. Pardon me. So front desk, again, make sure everything's set up properly for them. Pharmacies are huge for front desk staff, scanners, and flagging that location and status. For the clinician, opening the note, make sure the notes are all there. So I'm focusing on notes here, making sure you have the right notes and that the providers have approved them. And hopefully all they'll have to do is review all of their current and historical information because it was abstracted and loaded as verified. For the physician, basically the same thing. Notes, very important, and the review process. Not having to verify data when it goes in is a big deal for them. All right, that is all I really had. Again, I know it was a short webcast. I'd like to really get into it more piece by piece, but I think we'll save that. And again, if you have any interest or any of your friends need to talk to someone about transitioning, please let us know, and we'll sit with them and hopefully be able to plan that out for you. I'm going to swing over to the questions panel to see if there's any questions out there for me, and then I'll let you go if there's not. All right, let's see what we have here. Okay, I'm not seeing anything. Well, somebody told me I need to change my slide, and I'm sure that was like, 13 minutes ago. So thanks, Mark. I hope I changed it for you, one of my colleagues. And I don't have anything else. So thank you all so much for coming and listening to me. I hope it helped in any way possible. And again, if you need us, give us a call, and we'll be happy to help you with your transition from paper to the electronic health record. Have a good weekend, everyone. Bye-bye.